My name is Shanine Phoebe Morales, and my topic for today is about bicarbonate. Bicarbonate is the second most abundant an ion in the ECF. Total CO2 comprises the bicarbonate ion, which is HCO3, H2CO3, and dissolves carbon dioxide with HCO3, accounting for more than 90% of the total CO2 at physiologic pH. Because bicarbonate composes the largest fraction of the total CO2 measurement is indicative of HCO3 measurement. HCO3 is the major component of the buffering system in the blood. Carbonic anhydrase in RBC converts CO2 and H2O to H2CO3, which dissociates into hydrogen and bicarbonate. HCO3 diffuses out of the cell in exchange for chloride to maintain ionic charge neutrality within the cell. As you can see in figure 16.4, it shows how chloride shift works, and it is tackled in different reporter. This process converts potentially toxic CO2 in the plasma to an effective buffer, which is the bicarbonate, and bicarbonate buffers excess hydrogen by combining with acid, then eventually deassociating into H2O and CO2 in the lungs, where the acidic gas CO2 is eliminated. Regulation. Most of the bicarbonate in the kidneys, 85%, is reabsorbed by the proximal tubules, with 15% being reabsorbed by the distal tubules. Because tubules are only slightly permeable to HCO3, it is usually reabsorbed as CO2. This happens as bicarbonate, after filtering into the tubules, combines with hydrogen to form H2CO3, which then deassociates into H2O and CO2. The CO2 readily diffuses back into the ECF, and normally nearly all the HCO3 is reabsorbed from the tubules with little loss in the urine. When HCO3 is filtered in excess of hydrogen available, almost all excess bicarbonate or HCO3 flows into the urine. In alkalosis, with relative increase in HCO3 compared with carbon dioxide, the kidneys increases excretion of bicarbonate into the urine, carrying along a cation such as sodium. This loss of bicarbonate from the body helps to correct the pH. Among the responses of the body to acidosis is an increased excretion of hydrogen into the urine. In addition, bicarbonate reabsorption is virtually complete, with 90% of the filtered bicarbonate reabsorbed in the proximal tubule and the remainder in the distal tubule. Clinical application. Acid-base imbalances causes changes in HCO3 and CO2 levels. A decrease HCO3 may occur from the metabolic acidosis as HCO3 combines with hydrogen to produce carbon dioxide, which is exhaled by the lungs. The typical response to metabolic acidosis is compensation by hyperventilation, which lower PCO2. Elevated total CO2 concentration occur in metabolic alkalosis as bicarbonate is retained, often with increased PCO2 as a result of compensation by hypoventilation. Typical causes of metabolic alkalosis include severe vomiting, hypokalemia, and excessive alkali. Determination of CO2, the specimen used is serum or lithium heparin plasma because it is suitable for the analysis. Although specimens should be anaerobic for the highest accuracy, many current analyzers, excluding blood gas analyzer, do not permit anaerobic sample handling. In most instances, the sample is capped until the serum or plasma is separated, and the plasma is analyzed immediately. If the sample is left uncapped before analysis, CO2 escapes and level can decrease by 6 millimole per liter per hour. CO2 measurements may be obtained in several ways. However, the actual portion of the CO2 being measured may vary with the two method used. The two common methods are the ISE and an enzymatic method. One type of ISE for measuring total CO2 uses an acid reagent to convert all the forms of CO2 to CO2 gas and is measured by a PCO2 electrode. As you can see, it will be reported in Chapter 5. The enzyme method alkalinizes the sample to convert all forms of CO2 to HCO3. HCO3 is used to carboxylate phosphoenol pyruvate or PEP in the presence of PEP carboxylase, which catalyzes the formation of oxaloacetate, as you can see in equation 16 to 4. This is coupled to the following reaction in which the NADH is consumed as a result of the action of the malate dehydrogenase. The rate of change in absorbance of NADH is proportional to the concentration of the bicarbonate, which is shown in equation 16 to 5. So the reference range in carbon dioxide venus 23 to 29 millimole per liter in plasma or serum. That's all. Thank you.